All right. Good morning. Good to see you all again. Um, just an announcement. Paper number one. It should be available on, at least the topic should be available on Canvas, so you can see it there, and you should be able to upload your paper once you have it done. If you have it done already, I noticed that someone has already uploaded a paper, so good for you, getting it done early. Try not to wait. Because I was a little bit late with putting the topic up, I've extended the deadline to the 29th, just so you know. So we have until the end of next week, a week from this Friday, to upload the paper. So you upload it in Canvas, and I'll grade it after the 20th. Start grading it on the 29th and after. So just so you know, this month is Hispanic Heritage Month. And so to acknowledge and honor that for the next several classes, just for a few moments before I get into the lecture proper, I'm going to talk about American Hispanics, Hispanic saints, people who are either are saints or on the path to sainthood in the Catholic Church, people who have affected the history of our country, and have been part of our country. And so I want to start today by acknowledging, I guess, the only American Hispanic saint that we have, Saint. There are others. There are blesseds and there are servants of God. There are different levels of sainthood along the process as they determine whether they're going to canonize somebody. But this man, Saint Junipero Serra y Ferrer, a Franciscan friar. If you can't tell from his habit is just a religious term for his garb, for his clothing. Junipero, or juniper in English, Serra y Ferrer. I don't know how contemporary this picture is to him. It says in Spanish down here, if you can see it, that it is a picture of him taken from the original, so I'm assuming that it's generally accurate to what he looked like. And who was he? He was born on the island of Majorca, which is part of Spain. I actually took a trip there. It's a beautiful island if you ever get to go see it. But he was born on this small island of Majorca, which is off the eastern coast of Spain. So it was part of the Spanish Empire or the Spanish Kingdom. He was born in 1713 and he died in 1784. And in 1749, he went to Mexico to be a missionary for his order called the Franciscans. Franciscans because they were founded by a man named St. Francis of Assisi. Maybe you've heard of him. But their official title is the Order of Friars Minor, the Order of the Lesser Brothers. You know, it's a sign of humility that they weren't the great brothers, they were the lesser brothers, the servant brothers, the minor brothers. So he goes to Mexico and he began his ministry in what is now California in 1769. Hence, that's why he's considered an American saint, even though at the time, the southwest of, the whole from Texas all the way to the west to California was all part of the Spanish Empire at the time. It was all part of what we now call today Mexico. And there were other, Central America and South America were part of the Spanish Empire too. But for our purposes, the northern part was mainly Mexico. And so it was under the Spanish Empire. And the Spain were all over the place. They weren't just in the southwest and in the west. They were also in the east. Florida. Florida was a Spanish colony, La Florida, until I think it was Andrew Jackson, who was one of our presidents. He was a general, and he illegally invaded La Florida, then killed the Spanish governor, executed him, and took it over. I don't know if he asked to do that, but he just decided to do it. And that kind of ended Spanish control over Florida. But anywho, so that's why he's considered an American, because eventually this region of California, obviously, it was its own republic for a period of time, but then became part of the United States. Now, when he did this, he was evangelizing the local Indians in California, bringing the gospel, the news about Jesus to them. He established a whole mission system, the misiones, which were encampments in a way where the local Christian population, the Indian Christian population, could congregate and could live. They would live in the missions as well. And these missions, they have a kind of an ambiguous positive and negative significance for some people. For some people, they were like death camps for the Indians and their culture, because they were brought into Christianity and they were brought into Spanish culture, and they kind of lost their Native American culture in the process. But on the other hand, the positive elements were it protected them from, number one, their fellow Native Americans who wanted to kill them because they were seen to be kind of maybe collaborators or have gone over to the foreigners, but also to keep them away from the other Spaniards, who Junipero Serra did not have a high opinion of his fellow Spanish colonizers, especially the soldiers, because they brutalized the Native Americans. They treated them very badly, and Serra complained about this a lot, especially to the Spanish governor, and tried to get the Indians recognized as human beings who had certain rights and should be treated as such. Not totally successfully, but nevertheless, the missions that the Franciscan friars set up all through California, up the coast and down the coast, from San Diego to San Francisco in the north, San Diego in the south and San Francisco in the north, were supposed to be places where the Indians could find peace and safety. But nevertheless, some people take a negative view of them. He was, the guy was a tough person. He was 56 when he came to Mexico, and he was asthmatic. So he had a medical condition. He had a couple of medical conditions. First of all, he was asthmatic. And secondly, somewhere along the line, he got apparently bitten by an insect or something, and the bite got infected and didn't heal properly. So for the rest of his life, he had an ulcerated leg, which caused him a lot of pain. And he himself traveled to all these missions up and down the coast of California, and he was doing it on foot or maybe on an animal, a pack mule or something, which is not very comfortable, but on foot as well. And he's doing it with this bad leg, which has this ulcer. So the guy was tough as nails. I give him credit for that. I don't know that I could have done that. In 1784, I said he died at the age of 70. He died at the Misión San Carlos Borromeo, St. Charles Borromeo, from tuberculosis, apparently, and was buried. He was beatified in 1988. He was declared a blessed. There's a whole process for becoming a saint. First, they recognize that you were a holy person, and they call you a servant of God. Then when they realized that you showed heroic virtue in living out the Christian life, meaning that you were a Hall of Famer in a way. You lived out the Christian life more deeply than was necessary or called for. You become venerable, which means you can be honored. You can be publicly venerated in the church. Then they're looking for a miracle. They're looking for some kind of spiritual evidence that you are a saint or were a saint. And if you get a miracle, then you're beatified. You're declared a blessed. And the final stage, you get another miracle, a second miracle. Then they say, okay, that's pretty good evidence that God is giving his stamp of approval to this person, and you can be officially declared a saint and put into the calendar of saints and be honored in the church. He was declared a saint eventually by His Holiness Pope Francis, our Pope Francis, the current Pope, in 2015. And so now he's on the calendar of the American church as a saint. And he's the one and only, unfortunately, because there's so many Hispanics in the life of the church, but he's the only Hispanic saint on the calendar. And so I mentioned him during Hispanic Heritage Month, and I will mention other people as well. I'll go down the list. Started with a saint. Next Thursday, I'll start with a venerable, and then I'll go down the list to the servants of God. I wonder if we have a blessed. I think we do have a blessed. I should do the blessed before I do the venerable. But anyways, so Saint Junipero Serra y Ferrer, please say a prayer for us to Christ our God. Amen. All right, let's see here. Got someone else come in. I just want to make sure I have everybody. Ms. Weir. There you are. Leicester City won this weekend, Ms. Weir. Leicester City won. I'm a happy man. Crystal Palace lost, though. So, oh well. The Lord giveth and the Lord taketh away. Da 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 da. Principles of bioethics. Let's see here. We ended with, starting with autonomy. Did all this. Please note, I sent out an email. I did revise these definitions of the greatest happiness principle. Yes, Lester. Get back into the Premier League. That will make me really happy. And the rule of utility. Talked about that. Okay. I stopped with this common morality. Yeah, and the common morality is basically Beauchamp and Childress describe common morality as a kind of common sense morality. So even though they don't really claim a framework for ethical reasoning and decision making, they kind of do. They say, there are things that are just so commonsensical that everyone kind of knows it. Well, that immediately raises the objection of how does that happen? How do you? That's kind of an assumption you're making. But from culture to culture, do people really, and from civilization to civilization, do people really know that autonomy is a value or that veracity, truth telling is a value? Not necessarily. There might be disagreements, so their views can be attacked on that from that perspective. There's no also some people argue that there's a lack of ethical guidance with principalism because there's really no master principle when there might be a conflict amongst the various principles. If there's a conflict between, say, autonomy and beneficence, a physician trying to do the right thing or know what he or she should do for the patient, but the patient doesn't want it. I mentioned the recent case in the United Kingdom of the woman who has a mitochondrial degenerative disorder, something in the cells. I guess the mitochondria are what are they? The energy, kind of like the energy machines of the cells. But anyways, her cells are breaking down throughout her body, and it's going to kill her. I mean, there's no treatment for it. And but she wants treatment, even experimental treatment, which might not work. She wants to possibly go to Canada, where there might be a treatment that could help. But in her doctor, out of beneficence, her doctors want to do the best for her, and the best for her, in their view, is to start put her in hospice and give her palliative care to kind of ease her suffering as her body is slowly dying. So there are conflicts. There's autonomy. She doesn't want that. But there's also beneficence. Well, we're doing, at least doing no, or I should say also non-maleficence. We're doing good to you, what we believe should be done, but also non-maleficence. We're not going to do harm to you by giving you false hopes or by putting you through procedures that are futile, that won't do anything. What is autonomy? Autonomy is basically independence. I'm talking about autonomy. It comes from the Greek word autonomia, which means to be a law unto yourself, to be self-governing, or in a general sense, to be independent. It comes from the two Greek words autos, which means self, and nomos, which means a law, autonomy. What did I do? I want to put it here. Self and nomos, like the word norm in English, is a law, a rule, you could say. So you're a law unto yourself. Autonomy is the freedom and the ability to act in a self-determined manner. You decide what should be done to you as the patient, and it represents the right of a rational person to express personal decisions independent of outside interference, and on top of that, to have those decisions honored. So it's not like the physicians and the nurses are saying, yeah, we know what you want, but we're not listening to you. We're going to do what we want to do to you anyways. No, it's the person has the right to The person is reasonable. The person has reason and can express his or her wishes and wants certain things done or not done, and that those decisions should ultimately be honored. That's the principle of autonomy. Related to this principle is the idea of where we get informed consent. That and anyone who goes into medicine or the medical profession or the healthcare profession, you're going to know, because with informed consent comes paperwork. Lots and lots of paperwork, lots and lots of signatures, checking boxes, all sorts of stuff. So there's a whole bureaucracy around informed consent. But basically, what is informed consent? There's your definition. Complying or agreeing to something after getting an understanding of what is involved. Consenting, agreeing to something with information. You are given the information of what's going to happen. If you're a research subject, this is what we're researching. We're going to maybe give you drugs to see if they work. Some of those drugs may be placebos. It may not be the actual drug. So you don't know what you're getting. So we have a control group to see if the real drugs actually do something, or if it's just happenstance that something happens, whatever. So you're informed. You know all these things, and you can approve to that. You can agree to that. Say, okay, to be part of this research study on a drug, I will do this, even though I might not actually I might get a placebo and not get any actual medicinal benefit from it, but I know that going in. The Latin word I just give you for consent, consentio, is to agree with something. That's as basic as it gets. In order to be autonomous, it is essential to have the necessary information on which to base a decision. Okay, part of autonomy is knowing what's involved, so you can make the decision. You're a rational being, but for your reason to be interactive, you need to have the facts. You need to know what's going on in order to make the judgments necessary about what should be done to you. Thus, consent or agreement to proceed with a recommended course of action requires full information about the nature of the action, what's going to be done, the risks, and there are usually risks to medical procedures. Bad things can happen, God bless you. But what also are the benefits of such a course of action? Now, and you see this all the time on television when you see these commercials for various drugs and medications. They go through, they all kill you. So they tell you the risks. You could get an infection of the perineum, which could be deadly. I didn't know what the perineum was until I saw the commercial, but now I know. And it can kill you. But they have to tell you that in order for you to know what you're getting into when you take it. And usually they tell you that the risks are low, but there are risks, but there are also benefits. What can it do? Well, it can help treat your depression. It can make you happy instead of, you're not carrying around the unhappy face placard anymore. You now have a smiley face placard you're carrying around. Okay? So they tell you, you need to know these things in order to know what course of action you want to take. At the heart of informed consent is respecting the person's autonomy to make personal choices. Okay? Kind of in the background here is the conception of human dignity and human worth, which really isn't expressed in the principle of autonomy. I don't know why that's not made more clear in Beauchamp's and Childress's, but I think they're trying to get away from maybe a religious ethic into a more kind of atheistic, non-sectarian ethic. Something everyone can agree on. But kind of hiding behind here is this idea of human dignity that we'll get into later. Because you're respecting the person's autonomy to make choices of what should be done to himself or herself based on the appropriate appraisal of information about the actual or potential circumstances of the situation. Just a fancy way of saying knowing what could or might happen. I mean, you don't know what will happen. There could be complications that could be life-threatening, but what you think might happen, you base your judgment on that. That's part of basing your judgment with informed consent. Informed consent also presupposes that a person is psychically mentally, and morally available is a way of putting it. You're psychically and morally available or present to give consent. What does that mean? Well, it means that you're conscious, you're competent, you're capable, you're willing. Conscious means that you're awake. Very simple. You're not asleep, or you haven't been put to sleep. A coma is a form of sleep. Physicians will sometimes put people into comas, put them to sleep, because, say, an illness or an ailment is so severe that the body needs that extra effort to heal itself, and so they will put a person into a coma, an induced coma. But if you need to get someone's informed consent, they need to be conscious, they need to be awake and aware. They need to be competent, which means they need to be of a sound and rational mind. There's the definition of competence, being able to have the required or adequate ability to function, which for our purposes means, as I said, a sound or rational mind. So you're not a crazy person. You're not someone who's schizophrenic. It's probably diagnosed schizophrenic. It's probably a lot of times not competent to make decisions about his or her care because they don't see the reality properly. Or to be competent means that a person has proper understanding. So someone who is mentally disabled might need to have a guardian to make decisions for that person. Okay? Because they don't have that understanding, that level of understanding. Hello, Mr. Thatch.
How you doing?
I'm fine, thanks. How are you?
All right.
They don't have that level of understanding that they need to give their consent. Let's see, Mr. Thatch, where are you? Okay. So how about Mr. Thomas? And I give you the Latin words there for consciousness. I didn't go over the definition for consciousness, but the definition being able to exercise one's mental abilities with awareness, from the Latin words cumscio, to know. Cum means with, so to know with, to know together. And competence comes from competo, to meet or come together. You have to be capable, meaning you have to be capable of giving consent, which means, you can be a rational person, you can have proper understanding, okay, you can be awake, you can even be willing, but you might not be capable, you might not be of the right developmental stage. So, for example, for true informed consent, you need to be an adult. Otherwise, if it's a child, you need a guardian to make decisions for that child. They're not of the right developmental stage. Also, to be capable, you need to be of the right state of mind. You don't want to be drunk or under the influence of drugs or something like that. And you have to be willing. You have to have the full use of your will for the consent to be valid. So, for example, the consent must be voluntarily given. It must be uncoerced. You can't threaten the patient into giving consent. Like, if you don't give your consent, then I'm not going to do something for you, or I'm going to harm you, or I'm going to do something bad to you. So the person has to be willing. Now, an offense against this idea of informed consent, and something that was very much what I'm told. I mean, I wasn't there. I wasn't a doctor 50 or 60 or 70 years ago, but I'm told was an issue many, many years ago in medicine, and is still kind of an underlying issue, is this idea of paternalism, what's called paternalism, from the Latin word pater, for father. What's the matter? Yeah, paternalism always makes me grin. Paternalism implies that practitioners, the healing professionals, understand best what is best for patients. You see there the definition. The physician's act of overriding or intervening in the free, informed, and autonomous choices of a patient. Now, obviously, there are times when a physician might have to intervene. For example, as I told you, let's say the patient is in some way not fully present, like a person who is mentally ill or a person who is in a coma. I mean, the person in a coma can't say yes or no. So if a medical issue comes up while the person's in the coma, the physician is going to be the one who has to make the judgment call about what to do. That's not necessarily paternalism per se, I would say. No pun intended. Paternalism is making an active decision to not really respect the autonomy or the decision-making ability of the patient. And how did I guess I'll go on to that. Oh, that's below here. So that's there. Out of order, and we'll go to this. Just add the slides are out of order.
I wouldn't use the word fault tolerant. Okay. Put it your way. Two 24-year-olds can't seem to make a baby. Obviously, one of us is malfunctioning. Who? Jenny. All right, then we'll adopt kids. Oliver, the problem is more serious than that. Jenny is very sick. Define very sick. She's dying. That's impossible. I'm sorry to have to tell you this. That's impossible. Well, it's a mistake. It has to be. We repeated a blood test 3 times. There's no question about the diagnosis. She'll have to be told soon. We can withhold treatment for a little while, but not for long. We'll have to begin therapy sometime during the next few weeks. She's only 24. Will it be painful? Hopefully not. You'll, of course, want to speak to a hematologist. I can refer you to Dr. Addison. Yeah. What do I do? I mean, what can I do for Jenny? Act as normal as possible. For as long as possible. That's really the best thing. Normal. Normal, okay. I'll be as normal as hell.
Ready? Get to that in a second. That is a clip from the movie Love Story, which came out in 1970. So if you've ever seen a movie that has the basic premise of 2 people come together, they meet, they fall in love, and then they find out that one of them has a terminal illness, and then the rest of the movie is basically the one person watching his or her loved one die before their eyes, and it's kind of like a weepy movie. It's meant to make you cry. The person doesn't come back in the end. There's no happy ending. The person dies, and the living person has to go on with his or her life. Then you have Love Story. Basically, Love Story set that genre. It's a famous movie. I watched it once. It was okay. It's not a movie I would ever watch again. But it kind of set that whole genre where he comes together with this woman, and as you find out, as you see in the clip, he goes to the doctor because they're having difficulty having children, and finds out that she has some sort of terminal illness that's going to kill her, and he'll be left alone. So that's it. It's kind of any movie that's come since then is basically owes its beginning to this movie of Love Story. Now, why did I show this to you? Because it's an example, I think, of paternalism. Maybe not a hard paternalism, but it's certainly a soft paternalism. How? How so? Why do you think it's a form of paternalism? Or why do you think I think it's a form of paternalism? What indicates it? Yes, Ms. Pullman.
Because the doctor is suggesting what we should do and how to go on.
Okay, good. He's talking. He's talking about how the husband or married, how he should go on with his life after the woman dies. Yes, yes, Ms. Mitchell.
He's talking to the husband about the wife's diagnosis and like kind of overriding her ability, I guess, to like maybe process that information.
Interesting. Yes. Is she there? No. I'm presuming she's in the hospital. I believe she is in the hospital. What does he say think about what the words that he uses to talk to her husband about her condition. What does he say at one point after he tells him that Jenny is dying? Yes, Mr. Dietzel.
He said like it won't hurt, hopefully.
It won't hurt. Good. So he's concerned about her well-being, that it won't hurt. I'm presuming when he says that they're going to give her therapy, they mean like palliative care, because he says she's dying, so presumably incurable. But that's a good point. But I'm thinking about just something he says in passing to the husband about the wife's condition and what needs to be done about it. Yes, Ms. Bishop.
He says act as normal as possible for as long as possible. Like they're not going to tell her until it's like.
Ah! Remember what he says? She'll have to be told eventually. What does that tell you, Ms. Mitchell?
That they're not going to tell her until it's like necessary.
But also that they haven't told her. The lady's dying. They've run 3 tests. They haven't told her the results of any of the tests. Apparently not. So you have now. I don't. Again. Just I don't know if this ties into like a female thing because she's a woman. You got 2 guys talking about the situation and what they're going to do. The doctor's a male. I don't know if there's a sexist element going on, but certainly there's this paternalistic element of the doctor who has all the information, knows the tests have come back as they've come back, knows the situation and the prognosis for the patient that it's not good, and still it hasn't occurred to him that he should talk to her and tell her what the situation is, so that she can maybe make a decision. I don't know what decision she could make, to look for other therapy or just to prepare her for death. He tells the husband first. And when he says she'll have to be told eventually, is he asking the husband to do that? What do you think? You think, Ms. Reyes, you think so? Well, I saw a nod of the head. I thought you were saying yes. Maybe, I don't know. I can't, not specific, but again, yes, laughing, yes, terminal illnesses. They always bring a smile to my face, yes. No, you're such happy people. It makes me happy too. No, I'm not joking about terminal illness, but yeah. So I remembered this clip from the movie, and it's not a bad movie. If you want to see it because it was groundbreaking. It was a popular movie, groundbreaking for that type of genre if that's what you like. But I thought it was a good example of maybe the attitude. You talk people. Physicians and nurses kind of talk about their patients. Even to this day, I think it exists to some extent where doctors and nurses are talking about their patients before the patient even knows what's going on. That could be seen as a form of soft paternalism. Healthcare professionals may be tempted to act, but this is where it becomes problematic, is when a healthcare professional, a healing professional, is tempted to act in ways that they believe promote a patient's well-being, which we would call beneficence, according to ethical principlism. But when the actions are actually a violation of the patient's right to exercise self-determination, autonomy. What would be an example of that? Well, say a person has high blood pressure already, and a nurse avoids telling that person that She has high blood pressure. Her blood pressure is elevated because the nurse believes it's not in the best interest to give that information because it will upset the patient and further elevate the patient's blood pressure. Now, that seems maybe like a reasonable paternalistic response, but they're maybe not so reasonable because there are other ways of handling that. The nurse could tell the patient in a non-hysterical way, non-excitable way, that yes, it indicates that your blood pressure is high, but also indicate what we're going to do about it, so the person doesn't freak out and think, "Oh no, I already have high blood pressure. What am I going to die? Am I going to have a heart attack or something?" You can help calm the person down, but you're giving them the information they need to know what they need to do or what needs to be done, so they can say, "Yes, okay, let's do this so that my blood pressure comes down." Basically, paternalism is the doctor or the nurse knows best. So the physician or the nurse doesn't feel like he or she has to tell the patient anything or explain. And in an extreme form, it may include putting even physical constraints on a person. And I don't mean tying a person to his or her bed, but doing things physically to a person that person does not want done. And so we have here, for example, the court case that was 1914 that came about in New York. I'm assuming her name is pronounced Schlurndorf. Well, Schlurndorf in German, but it could be Sklondorf. I don't know exactly how it's pronounced. I'll say Sklondorf, versus the Society of New York Hospital, where this woman named Mary Sklondorf came in because she had a fibroma, which is nothing. It's a tumor, but any kind of growth of cells is a tumor. Not all tumors are bad. And she had a fibroma, which is a form of tumor, but it's just, basically cartilage or tissue that can be easily removed. It wasn't life-threatening. But she had a fibroma that was removed during surgery contrary to her wishes. She said, "Leave it alone. I don't want it removed." They did surgery on her, and they decided, well, and I think it might have been an exploratory surgery. They were looking at something else, but in the process, they decided, well, we'll remove it anyways, even though she said she didn't want it removed. They were doing a surgical they were doing a surgical exam on her. However, and she might not have even known about it, except they screwed up the surgery, and she got gangrene in her left arm, which required the amputation of some of her fingers. Because of that, she sued them in the New York courts and won a judgment for medical battery. You have assault and battery. Assault is if you swing at someone and you miss. You try to punch somebody, that's assault if you didn't hit them. But if you actually connect and hit the person, then that's not just assault, but that's also battery, according to the law. And the New York Court of Appeals ruled that, yes, she was battered by these doctors because they forget about that they screwed up the operation, but they did something in the operation that she specifically said not to do, that she did not want the fibroma removed. And so they did something physically to her that was against her wishes. So this is an example of paternalism that goes wrong, where a surgeon is in the midst of performing a surgery, and sometimes a surgeon might see something that's damaged that needs to be repaired immediately. That's not paternalism. That's a doctor doing his job or her job. But if they decide, this person has a mole here, maybe they don't want it, I'll remove it. Which is a minor example, but it's an example. That could be something that is a form of paternalism that is violatory or violative of the person's autonomy. Although paternalism was once a common practice amongst healthcare professionals, because you would typically defer to the judgment of the doctor or the nurse, in general, healthcare professionals are discouraged from being paternalistic today. It's a bad word nowadays, whereas before it might have been standard practice in medicine. Beneficence comes from the Latin word bene, which means well, bien in Spanish, okay, it's Latin-based language. which comes from the Latin word bonus, which means good. So to do good to people. So that's basically what beneficence, literally what it means. Okay, it's no fancy, there's no fancy meaning to it. To do good or to produce a good. And beneficence is that the action of a physician should do some good or be of some benefit to the patient. The physician is taking an action to benefit and promote the welfare of other people, in this case, the patient. And because of professional standards and social contracts, there is kind of an implied, at least, social contract in a society that a person goes to a doctor to be healed. That's, i.e., something good is going to be done, not something bad. So that's the understanding. Physicians and nurses have a responsibility to be beneficent in their work. And this is stated up front, for example, in the Code of Ethics for Nurses with interpretive statements. That's the title of the work. I'm not, the Code of Ethics for Nurses with interpretive statements, which says right up front that the patient's interests and well-being is the primary concern of the nurse. So beneficence. Put that on here? No, I don't. So I'll just say it. What are the rules of beneficence? Well, first of all, to protect and defend the rights of others, to be zealous in the protection of your patient and for the interests of your patient. To prevent harm from occurring to others, specifically the patient. To remove conditions that will cause harm to others. So, for example, there's a big push in the last 5 or 10 years in a lot of hospitals to have, antibacterial soap available throughout hospitals. Why? Because they realized that they were potentially harming patients because there were a lot of infections that were arising amongst patients, probably due to people simply not washing their hands enough. Doctors and nurses being too busy to basically sterilize their hands from germs. And if you're a physician making rounds or a nurse, you're treating a lot of different sick people, so you can have a lot of different germs all over yourself. So now when you go into a hospital, every 10 feet or something, you have these contraptions where you push your hand in, you get your foam soap and antibacterial soap, and you wash your hands. So they're removing the condition that could cause harm to others. This is an example of beneficence. You're caring for your patients. Helping persons with disabilities, having a concern for those who are disabled or, say, permanently sick, in a manner of speaking, permanently ill. And rescue persons in danger. Okay, so people who are in a situation of danger, that you have EMTs and people, ambulance workers who are supposed to go towards the danger to help the person, not let the person stay in that situation of danger. That's also an example of beneficence. And these are all coming from Beauchamp and Childress's book, Principles of Biomedical Ethics. These are things that they're explaining you should do. God bless you. On the flip side, and maybe the other side of the coin, is non-maleficence. Male means badly, to do something badly, or bad. Faccio, to do badly. An act of committing harm or evil, a bad action. Maleficence itself comes from the Latin word maleficus, which means evil doing. Very basic, evil doing evil, but it can also mean wicked, it can mean criminal, hurtful, and injurious, causing injury to someone. From maleficence, we get our principle in Latin, which you may have come across, primum non nocere. Primum non nocere. Primum, first. Prime, have this in English. Prime means first, primary. Primum non, not. And nocere you might not recognize, but is to harm in Latin. So just the phrase is primum non nocere, do no harm in Latin. And I give it to you because you will see it oftentimes as a Latin phrase. So I want you to recognize it. Now, you should not do any harm unless, of course, Ms. Serna, you are Dr. Giggles. And then you can do as much harm as you want. Ah, yes. If you're from Moor High and you get sick, fall on your knees and pray you die quick, Ms. Bose. Certainly don't go to Dr. Giggles because you won't get better. This is a horror film from the 90s that I saw. It was okay. And of course, he's called Dr. Giggles because he has a crazy giggle. He's insane. He's an inmate from an insane asylum who thinks he's a doctor, but all he wants to do is cut people up and kill them. Certainly, he is not practicing non-maleficence. This concept of non-maleficence is deeply rooted in healthcare. It goes as far back as the Hippocratic Oath. Okay? And I think in the Hippocratic Oath says when the doctor goes in, you should at least do no harm to the patient. So it's there. This principle is there. And it means that people have an obligation to not deliberately inflict harm, physical or emotional, on others. This involves duties such as not killing, of course, not directly killing the patient. Obviously, doctors and nurses will sometimes joke about, oh, I remember the first time I killed a patient, by which they mean they made a mistake. They misdiagnosed something or they did something accidentally wrong, not intending to harm somebody. They were not trying to be maleficent, but it ended up in the death of the patient. And so there's kind of like a morbid gallows humor about it. Oh yeah, I killed the patient, They take on that blame. But no, direct killing certainly should not be done, nor causing pain and suffering, nor causing offense or depriving the goods of life to a person. So just as simple as something as you feed a patient. A person's going to be in the hospital for a while. You don't just treat the sickness, but you got to take care of the normal everyday activities of keeping the person alive, which means they have to be able to go to the bathroom. They have to be fed. They have to be kept clean and hygienic. Healthcare professionals have historically been encouraged to do good, which is beneficence. But if for some reason it's just not possible to do any good, they're required to at least do no harm. And this is, for example, where end-of-life care comes in, where there's no good that listening to the game, I guess. There's no good that can come of the any medical treatment that you can give the person. So at the best, you can do no harm to the person. Say, for example, giving them some morphine to relieve the pain, or opioids or something like that. Because of the two sides of the same coin connotation between these two principles, some people consider them to be essentially one and the same, but not necessarily. There is a distinction to be had between beneficence and non-maleficence. Now, when we think about medicine, for example, today we have a medical procedure that's going on campus. Does anyone know what's going on campus today? Ms. You know, there's a blood drive. There's a blood drive, which I guess we could call paramedical because it's not completely medical. You're not going to a hospital, but there are medical things going on, and the people have to be trained. The people who are doing it have to be trained. This is just, how does this tie into non-maleficence? Because there are many treatment modalities and diagnostic procedures in medicine which do involve inflicting some sort of harm on the patient. I mean, when I go to give blood later, they're going to have to put a needle in my arm. They're going to have to damage the skin. They're going to have to damage the lining of the blood vessel to get the needle in. They're removing blood from my body. So there's some harm in that. So there are always risks. Now you might say, well, isn't that violating non-maleficence? At least don't do any harm, because they're not doing me any good necessarily by sticking a big needle into my arm. unless it's acupuncture, then people might think that that's a good thing. But doesn't it violate at least not non-maleficence? Well, there are always risks. And the essential point for non-maleficence is that any adverse effect is unintended. The nurse or the phlebotomist, the person who is going to be sticking the needle into my arm is not intending the harm. They're not directly intending that there should be an adverse effect to me. And then the second point is that the benefit gain should exceed the harm, real or potential. Okay, so there is real harm being inflicted because skin is being destroyed, blood vessels being destroyed to some extent, not irreparably. I mean, it will heal, and it's not something that would harm my body and cause me great distress, although it could happen. There are people who have adverse reactions when they give blood. That's why I have to be careful with it. But the benefit gained exceeds the harm that's being done. It could be the case that even providing medical treatment may violate non-maleficence, this idea of not doing harm. And this is a principle that's called medical futility. And this applies to bioethics when you have a situation where there is a procedure that could be done on a person, but it won't give them any benefit, actually. It would harm them in the long run. Futilis in Latin means untrustworthy or worthless. The procedure is worthless. I mean, you can't accurately predict the outcome of every intervention, but futile treatments are treatments that a healthcare provider, when using a good clinical judgment, does not believe will provide a beneficial outcome for the patient. So for an example would be a patient whose body is in the stages of dying. And it's clear that it's in the stages of dying. And at that point, the stomach may stop, certain organs may start failing, like the stomach may stop digesting food. So force feeding the patient whose stomach will no longer digest is medically futile. And it's not in the best interest of the patient, even though, and you're not intending to starve the patient. That's different than taking the food or water away from the patient. It's a person who's in a stage of dying where they can't digest. It's medically futile and not good for them. Another example might be forcing an elderly patient to undergo a surgery that could kill him or her. Okay, there are certain ages where there might be surgical interventions that could occur, but the doctor knows that the person is so weak that he might not survive it. If it's successful, it would benefit the patient, but it probably won't be successful. There's a bad chance that it would be. So the surgeon could judge the intervention as medically futile and recommend not performing it. It happens all the time. The next principle is justice. Justice simply is we could also call it fairness. Treating people fairly, giving them what they deserve. In a religious, well, it's religious, but it's in a lot of religions, and it's usually tied with religion, but you can logically reason to this anyways. But the principle of do unto others as you would have them do unto you, the so-called quote-unquote golden rule. You'll see posters sometimes that will give the golden rule and show a bunch of religious symbols around them and say, show different variations of the golden rule in different religions. It's not necessarily a religious principle. I would say that you can reason to that just from simple justice. You do to a person what they deserve, and you expect them to give you what you deserve and be treated fairly. So that's what it means for healthcare ethics, that the patient is treated with fairness, that people are treated equally and without prejudice. And there is an equitable distribution of both benefits and burdens. Okay? Let me turn the page here. Regarding that last point of an equitable distribution of benefits and burdens, well, what does that mean? It means like managing waiting lists, who gets to see the doctor and when they get to see the doctor. That's an example of justice in action. I mean, it's a simple example, but yeah, you want people who need more attention, triage, who need more medical attention, get to see the doctor before other people who don't. Why? Because you're trying to determine who should have access to limited resources and treatments. The resources, the doctor, the physician only has so much time. The nurse only has so many patients and so much time. The person who's coding gets the attention first. If a person is in code blue, they're having a heart attack or something or a stroke, then that person is obviously out of justice going to get the attention before someone who has maybe an ingrown toenail in the next room and is in discomfort and pain, and maybe it's even infected, but is not possibly dying or in severe distress. Just looking at my notes here, I have an example here. I'm not sure if I want to show justice, but not sure how. I'll move on from that. Daraprim. You can ignore Daraprim. I'll move on to veracity. The last one, which I don't think Beauchamp and Childress make part of, and I mentioned this before, they don't make it part of their four-tiered principles, but a lot of times veracity will be added onto it, and you'll come across it a lot, so I add it here and I mention it. Truth-telling, the word verax is where the word veracity comes from, simply means to be truthful. So being devoted to the truth. Now, kind of like paternalism, veracity was not necessarily a value for physicians or nurses in the past. You didn't tell the whole truth to your patient. Why? Because it might put the patient in mental distress. You didn't say things to the patient that might cause the patient mental harm. And so, for example, this man, Oliver Wendell Holmes, who I think was one of the justices of the Supreme Court, but he was also a physician, gave this talk, The Young Practitioner, to the graduating class at Bellevue Hospital in 1871. And he says right there, your patient has no more right to all the truth you know as a physician than the patient has to all the medicine in your saddlebags, or you could say your medical bag, if you carry that kind of cartridge box for the ammunition that slays disease. Making a reference to, you might carry a gun in your saddlebag if you're riding a horse and stuff. So that's your ammunition. So in your medical bag, you've got all of your drugs, your basic drugs and things that you can treat illnesses with. And you've got your stethoscope and other instruments, might have scalpels and whatnot. The patient should get only just so much as is good for him. And he goes on to talk about how the fact that you don't want to mention certain words like cancer or tuberculosis or things around the patient, because even if the patient doesn't know what they are, the patient will look them up and will scare himself, will get too worried, will worry that I'm dying when perhaps the patient isn't dying or something like that, or it's cancer when it's not cancer. So this is his view. This is a paternalistic view, but the principle of veracity that is the norm today requires the telling of truth, that you don't deceive the patient. You don't tell the patient that he or she is not sick when the patient really is sick, or you don't withhold the severity of the illness from the patient, because they need to know, they need to make decisions, even if those decisions are simply funeral arrangements. You might need to get your house in order and your affairs in order if you're dying, which you can't do if you're not told. It also includes the full disclosure of information to the patient. But veracity, similar to autonomy, is a cornerstone of the idea of informed consent. So autonomy and veracity kind of go together in the idea of informed consent, that the person should have the information in order to make informed decisions about what should be done to him or her, but they also need to be told the truth. What is the real situation in order to make that informed decision. Now, there is the idea of therapeutic privilege, which is, as paternalism is to autonomy, therapeutic privilege is to veracity. It's the belief that it is acceptable for the healing professional to withhold information if it is believed to be in the patient's best interest to do so. Therapeutic comes from the Greek word therapeuo, which means to serve or to heal. Notice the idea of service. It's a form of service. Healing is a form of service. And privilege comes from the two Latin words privus lex, which means a private law. So the question is, should a patient be informed of every single potential risk involved in undergoing a course of treatment? Can a healthcare professional withhold information when disclosure may do more harm than good, or when the act of disclosure may create a lack of trust between the patient and the healthcare provider? I'm not sure what the lack of trust might be. I've tried to think of examples, but if someone comes up with an example, you can tell me, but I don't know. I certainly think that, if the person doesn't feel like they're getting all the information, that creates a lack of trust, certainly with the healing professional. But there may be, for example, where as a physician or a nurse that telling the person that the person is dying or that the cancer, they have cancer, you worry for their state of mind, especially if it's a mentally ill person, what that person might do. Is suicidal ideation an issue? That might be a question. Okay, you have to take these examples as they come. Not every person receives information in the same way. A person might receive the information on an even keel and say, okay, what do we do? Another person might freak out and go into a deep depression, a severe depression, which makes it more difficult to treat. So sometimes there is this judgment call about how much do you tell? If there's an emergency, now there are situations where there's an emergency, or when the person waives a right. For example, in a research study, the patient is waiving his or her right to receive a lot of information because you have to protect the integrity of the study. You have to know whether what's being studied is valid or not. Okay, so the study is blind. People don't know necessarily what's going on from group to group, or if it's a case of testing medications, you don't know whether you're getting the medication itself or getting some form of other medication or non-medication at all, and they're not going to tell you because they need to protect the integrity of the results. So when you know this is an example of therapeutic privilege. The physician is deciding not to withhold information, but this is going on. Therapeutic privilege becomes a little bit dicey, a little bit questionable when it has to do with mistakes. A surgeon is in the process of operating and he nicks an artery and the person bleeds out on the table. Now, if it's not a major mistake and the surgeon is able to repair the artery and the person is fine, then maybe they might err on the side of not telling the patient about the mistake. They might invoke therapeutic privilege. It's not in the best interest of the person to know because there was no harm, no foul. Well, there was a harm, but there was no death involved. It becomes a little bit harder to claim therapeutic privilege when you have a corpse. Then you have to explain how the corpse got there. And if you cut a large part of the artery and the person bled out and died, then you're going to probably have to disclose that. There are strong arguments in the literature that support the disclosure of medical errors, and there's evidence they are in the literature. There's the argument that disclosure actually enhances the relationship between the patient and the healing professional because it increases trust. I trust that it's hard for me to get mad at you when I know you're trying to do your job, but accidents happen. and you're going to try to address the accident. It creates a level of trust, and it can also reduce the risk of litigation. I'm not going to, if you try, sometimes the cover up is worse than the offense. Admitting the offense, and this is what happened. I was trying to take blood from your arm, but I hit the brachial artery. It didn't do a lot of damage, but there will be excessive bleeding because it's an artery. Okay, fine. I understand that. Put a bandage on me and it will heal. Yes. Okay, fine. I'm not going to sue you. I understand that accidents happen. That might be the situation. Whereas when you get this impression that they don't want to tell them, that something went wrong, but they don't want to tell you, it can create a lack of trust there. And yet, the disclosure of errors is probably still not the norm in healthcare practice. In the past, medical or nursing patient care errors were something that were kept quiet, and care was taken to avoid that the patient would discover the errors. But nowadays, it's expected that errors involving certainly serious preventable adverse events are to be reported to patients, and there are other organizational reporting systems on a mandatory basis. So a lot of hospitals will have, what they call morbidity and mortality seminars. Morbidity would be where the mistakes are kind of addressed, or they want to ask the question, why did someone who probably shouldn't have died die? Or why did someone get sick who probably shouldn't have gotten sick? Was there a mistake made? And let's be transparent about it and address how we don't make that mistake again. Near misses, where you have errors that really cause no harm to patients, is a more controversial area for therapeutic privilege and veracity. Some professionals would tend to avoid telling patients about near-miss errors since no harm was done, but bioethicists would still recommend disclosure. So, for example, the radiological technology at a hospital has been miscalibrated, and people who have been using this radiological technology have received a little bit more radiation exposure than they thought they were getting. And certainly the professionals thought they were giving them until they realized, wait a second, this is miscalibrated. They're getting a little bit more radiation. Now, the exposure was non-lethal, didn't kill anybody, and it was likely that it was non-harmful, it was unharmful. Nevertheless, should the patients be told about it, that they were exposed to more radiation than they should have been? Ms. Reyes, you're nodding. Do you say yes?
Yes.
Why do you say yes?
Because they have the right to.
They have the right to know why. Why do they have the right to know? They weren't harmed.
Experience
Okay. So maybe something in the future could come up that might be connected to that extra little dose of radiation. Okay, possible. It's possible if it can be established. Yeah, it's kind of a gray area because at the end of the day, no one was physically harmed from it that we know of. But there was, it was not according to the standard of care that should have been given. So it's just an example of therapeutic privilege. Maybe being honest. Now, most authorities would acknowledge that therapeutic privilege should be invoked rarely and only under exceptional circumstances. The norm should be to try to tell the whole truth to the patient so that they know what's going on, even if there were mistakes made or not a mistake, but an accident. Okay, because and especially in teaching hospitals where people are learning how to do things. Okay, obviously, I mean, if a person has to poke you 3 times to take blood, that's kind of an accident. Ideally it should take 1 stick, but people have deep veins. A person might be inexperienced. Okay, and it's okay to say, okay, I'm still learning, and this is what I need to do to get your blood. They understand what's going on. They understand that you're not trying to harm them. So being honest and forthright with patients can promote trust, and certainly secrecy is considered unethical under veracity. Excuse me. Okay, get rid of that. Yeah, that's interesting. I'm just looking at my notes. I think I have something puzzled by this comment I have here that I think I put it out of sequence. Okay, that's ethical principlism. On Thursday, we'll talk about casuistry, which is another form of ethical decision making, which has become very popular in healthcare ethics. It's basically looking at cases, specific cases of what has happened to people and how they made ethical decisions about what to do about those particular cases. So casuistry on Thursday. Have a good day. Yes. Have a good day, sir.
But no. Yeah. I want to make you have a good day.
You too. Thank you, sir. I get to it. It's Thursday, so I'm not gonna worry about it.
Thank you.
Have a good day, Mr. Thatch. Thanks. Don't know. Goodbye, everybody who's watching.